and welcome to Ask the Expert, an informational short video to address an important topic in the world today, thrombosis and COVID-19. I'm Sam Perry, campaign manager for the International Society on Thrombosis and Hemostasis World Thrombosis Day campaign. Today, we are joined by Professor Beverly Hunt, OBE of the UK. Professor Hunt is a professor of thrombosis and hemostasis at King's College in London, and she is one of the world's leading experts in thrombosis and acquired bleeding disorders. Professor Hunt is the co-founder and medical director of Thrombosis UK and the chair of the World Thrombosis Day Steering Committee. We are very pleased to have her joining us today. Professor Hunt, thank you for your time.
Well, thank you for inviting me.
COVID-19 continues to spread around the world, and healthcare professionals are learning more about the disease each day. Experts from the International Society on Thrombosis and Hemostasis and the World Thrombosis Day campaign are researching the correlation between COVID-19 and thrombosis and have begun to create recommendations and guidance for healthcare professionals to treat patients. Professor Hunt has been a global leader in the research and understanding of COVID-19 and thrombosis and is here today to discuss this connection and to share important updates and information for healthcare providers. Let's start with our first question. Professor Hunt, can you tell us how the last 3 months have evolved and what you're seeing on the ground? How has this pandemic shifted your clinical focus?
Well, I belong to a big London hospital where we have basically closed most of our routine work. We do telephone interviews instead of face-to-face interviews with our outpatients, and we have devoted ourselves to managing patients who have COVID pneumonia. And so we have had many patients being ventilated on ECMO or in the general wards with COVID pneumonia.
Thank you for sharing that. Why are patients with COVID-19 getting blood clots?
So it's an interesting question because the data that first came out from Wuhan before we were really seeing large numbers of patients was that the patients had a disseminated intravascular coagulation, and that was a driver. But when they arrived, it wasn't at all like that. These patients are profoundly prothrombotic. And when we look at the patients, they have extraordinary levels of fibrinogen. Knowing fibrinogen is normally 2 to 4 grams per liter in an adult, maybe a bit higher with increasing age or pregnancy, we have been seeing levels of 10 or even 14, which is phenomenal in a sick patient. So I think that this prothrombotic state is extraordinary. We don't find the changes of DIC, so we don't see low platelet counts. Platelet counts tend to be at the top, really, of the normal range. Maybe the PT and the APTT might be very slightly deranged, but not consistent with a DIC. You know, in a DIC, you would expect a low fibrinogen. What we have found is extraordinarily high levels of D-dimer. And they were a little bit of a conundrum to start with. And I think a lot of people took it to mean that there was huge activation of coagulation. But actually, when you dig into the literature, you find that patients who have acute lung injury or adult respiratory distress syndrome have pretty high levels of D-dimer, and that probably a lot of that fibrin breakdown, because D-dimer is the fibrin breakdown product, is coming directly from the lungs. And extraordinarily to the hemostasis community, because we didn't really look at it before, pneumocytes can actually produce urokinase, and they can do fibrin breakdown. And then the other thing that we are seeing is large numbers of macrophages within the lung, and macrophages can produce urokinase, and they also have a very cute system whereby they can take in fibrin or fibrinogen through CD11B and pull it in a granule, and cathepsin, non-plasmin enzymes will break it down and then throw it out again. So I suspect that original data that said D-dimer levels were prognostic. When you get to the emergency department or you get to critical care and you measure the D-dimers, the highest levels are associated with increased mortality. Actually, they're reflecting the extent of pulmonary damage rather than saying, hey, these guys are really at high risk of thrombosis. Although, of course, they are at increased risk of thrombosis.
Based on your research, what are your recommendations for healthcare providers who are treating COVID-19 patients?
So it's not my research. Everybody has been contributing globally to producing data as soon as they can about the risk of thrombosis in the patients. And actually, it's a problem because we've got very premature data and ideally we'd like to wait 3 months after patients have been discharged and look back at them. We haven't got the time here because the pandemic is moving so fast. But what the data has said is there is a high rate of venous thromboembolism in these patients. And what's a bit odd about it is that normally if you look at venous thromboembolism, you'd expect a third of the events to be pulmonary emboli and 2/3 to be DVT. And what we are seeing is mainly PE. And when you look more closely, you actually see that what people are saying are PE is they've got segmental or subsegmental occlusions on CT pulmonary angiography. And we know that within profound inflammation, you can get thrombosis. And we suspect that what we're seeing isn't pulmonary embolism, it's in situ thrombosis because there's such bad inflammation in the lungs. And then we've got small pockets of thrombosis. We're calling it immunothrombosis. So when you look at the patients as a group, you have to say, actually, I think these are due to immunothrombosis on the CTPA. And then actually, this is a proper pulmonary embolism. Maybe the rates aren't quite so high as we first suspected. And so we're thinking, well, how do we move forward on these patients? If you've got thrombosis in a site of inflammation, it's being driven by the inflammation. So the question for a lot of us is, actually, the horse was bolted here. I've got all this inflammation going on and I've got thrombosis here. I can give anticoagulation, but I'm not dealing with the prime cause, which is this profound inflammation. Really, these patients need anti-inflammatories or antivirals or not to get COVID in the first place. It needs to be managed upstream. So whether anticoagulation affects immunothrombosis, we don't know yet.
You had mentioned previously a little bit about patients after discharge. Are there additional precautions for COVID-19 patients after they've recovered and after they've been discharged? Should healthcare providers provide additional anticoagulation treatment?
Okay, so we haven't really discussed inpatient thromboprophylaxis. And I think the world has decided that it's such a risk factor that anyone who's admitted with COVID should have thromboprophylaxis. And actually, if you look at medical thromboprophylaxis guidance, if you have somebody with acute pneumonia, they should be put on thromboprophylaxis if they've got a little bit of immobility. So yes, as an inpatient, you would be getting thromboprophylaxis. The big question about inpatients is, should I increase the dose of anticoagulation to try and reduce the risk further? Or is it going to create increased bleeding risk? So there's a lot of controversy there, and different hospitals are doing different things, and we need research there. Then we've got the issue of we may well have had somebody who's been very sick, maybe on a ventilator for a couple of weeks, going home, probably with quite a lot of reduced mobility, could lose a lot of muscle bulk if you're on mechanical ventilation. And so we have got two schools of thought. In the US, they have had drugs licensed for use post-discharge medical patients and that's Matrixaban and Rivaroxaban, recently got a license in the US on the basis of trials. In Europe and elsewhere, they've looked at the data and said, well, there's a minimal benefit, but it's a hell of a lot to give a patient a month's DOAC after discharge. I think we should continue as we are because of the costs and the lack of data on cost efficacy. However, COVID's come along and we've all seen this profound prothrombotic state and how sick the patients are. And a lot of people would like to give thromboprophylaxis, post-discharge extended thromboprophylaxis. And looking around the world, I think most people are considering giving 2 weeks thromboprophylaxis at least, although we need, again, to do some decent randomized controlled trials to look at this.
What research are you working on currently in relation to COVID-19 and blood clots?
So it's not just me, it's the world. We're all eager to know, if I give thromboprophylaxis, what's the best dose of anticoagulant I give? And then also, should I give thromboprophylaxis after discharge? If I do, for how long and how much? And then we've got the really difficult area of where there's just nothing. I've got a patient who's pretty high risk of having blood clots, but not on long-term anticoagulation, and then they get COVID. Should I be thinking about giving them some form of thromboprophylaxis in case they go on to get COVID pneumonia? And that is a really difficult area because it's not really been the subject of research before.
Do you have any additional thoughts on what you believe healthcare providers should know as they're treating COVID-19 patients?
I think the other issues are around mechanical thromboprophylaxis. So we've got graduated compression stockings and we've got intermittent pneumatic compression. I think the current evidence on stockings is, are they of any use at all? We've got the GAP study, which came out a couple of weeks ago in the British Medical Journal, and it randomized a couple of thousand patients undergoing moderate risk surgery to pharmacological thromboprophylaxis. And underneath that, they had stocking or no stocking. There was no difference in VTE rates. They were both very low. So that sort of goes against stockings. It was the first big RCT of using stockings in that way. But there is evidence for intermittent pneumatic compression. So if you've got somebody who's very high risk, I would consider adding in intermittent pneumatic compression if they have poor mobility.
Excellent. Thank you, Professor Hunt. We have one final question for you. Can you share a bit about the World Thrombosis Day campaign and how healthcare providers can benefit from becoming a partner?
So thank you for that. So World Thrombosis Day is a campaign to improve awareness of thrombosis, particularly hospital-associated VTE at this current time. And we are working with the World Health Organization to increase awareness and looking particularly at COVID. We're also trying to increase awareness in the general public. And that's quite interesting how varied people's knowledge is across the world. And we are doing ongoing work there. So please join us. It would be great to have more healthcare professionals associated with this fantastic organization.
Professor Hunt, you've shared some great information with us today, and we are very appreciative of your time. As we close out this Ask the Expert, continue to check out the World Thrombosis Day and ISTH websites and social media for the most recent updates. Thank you all for joining us today. Stay well and stay safe.